Best for the last. Over to you, Suhas.
Well, now this is a case of weak endothelium, very bad fuchs. Now these are the cases where there are some very special care that one has to take. And for one thing, anyway, for a cataract surgery, a scleral tunnel is a better tunnel, but making a clear corneal is so easy and so quick that we tend to do it. But if you do a scleral tunnel and if you start operating, you literally can see that you are so far away from the endothelium, and you know that you are definitely much safer for the endothelium. Now this is a case in which I make a scleral tunnel, then inject dispersive viscoelastic. You have a nice coat of that, and underneath you inject sodium hyaluronate. It kind of pushes your dispersive onto the endothelium. In fact, today if I had to do, I would go with PSS under the sodium hyaluronate and create a third space, because that's a space. Suppose this case was not with so much of a glow, and if I had to put staining, to do staining under the viscoelastic sometimes becomes little difficult. So you can always have BSS as your third coating, and under that you can do your staining. But in this case, with Helon there, I'm able to do an easy rexus. I'm able to go ahead with my procedure. And what I should remember all the time is my flow rate is kept minimum. I tend to have a very slow kind of a phaco where you don't really work on very high parameters. And the thing is, I'm used to a horizontal phaco, and for that you literally go to the periphery, break them, bring them to the center, try and cut them into smaller pieces, and all your tendency to do it quick has to be dampened, because anything that you do very close to the endothelium can be very hazardous. And in between, at least 2 to 3 times, you can go with viscoelastic. At such times, going with your Helon or sodium hyaluronate doesn't help you much. It's either your methyl cellulose or your dispersive viscoelastic like chondroitin, or maybe if you have an access to Helon 5, maybe Helon 5 probably could be the good one, because that gives you a much better coating than the other viscoelastics. And if you do not have an access to that, methyl cellulose is much better than sodium hyaluronate for this action. But for the final action of injecting your viscoelastic, I think nothing beats sodium hyaluronate, because the trick is you would not want to do too much of irrigation to get the viscoelastic out, and the quickest way a viscoelastic comes out is only with sodium hyaluronate.
It looks like a very well done normal cataract surgery. What was the challenge in this?
The endothelium was extremely bad. You really don't get a good focus on that, but the central endothelium showed quite an advanced guttate changes.
So summarizing, what about phaco parameters? What all will you do in this case?
My phaco parameters for this would be low flow rate, and even the vacuum would not be very high, and I would go about very slow phaco.
Yes, Kumar, you wanted to comment?
No, my thought would, when would you indicate a DZEC with a cataract in such, okay. Amar is shouting at me, but when would you indicate something like this? What would your indication be? At what level of visual acuity?
What you mean to say, triple procedure? Normally, if you look into Indian scenario, there are 2 important things. One is corneal thickness. Second is the endothelial picture. So if you have a corneal thickness less than 1000 square per millimeter, and your CB is less than 0.3 or 0.2, and patient is symptomatic, and cataract is significant, you can plan, combined procedure. But case like this, I would do a phaco surgery first, do an inferior PI during that time, and let the eye be quiet. Maybe in the next 2-3 months, I might do a DMEC, or Amar will do PDEC, and somebody else might do a DSEC.
I apologize on behalf of the two gentlemen sitting on my left, sir. They were mentioning DSEC while you are there. Please, what would you have done?
DSEC is this fellow. He doesn't do DSEC. We do DMEC and PDEC.
See how Abhay is making fun of me. But yes, I do only PDEC because of simple reason. One, you are using a young donor. In DMEC, your donors are above 40-50 years of age. In PDEC, you're using only young donors. The second big advantage in PDEC, unlike the DSEC, is you're only 25 micron. And the third big advantage, obviously, is very easy compared to the other two procedures. So I definitely think it should be PDEC anyway.
No, but Amar, your comments on when you will do a
Same,
DMEC with the,
same.
is this the same?
Same. Only PDEC, you can't take more than 7.5.
The
8
key word is
millimeter
PDEC,
size.
not DSEC. That's what
While
he said.
DMEC I take 8.5, 9 millimeter. So I
No,
get
there's
more
some
tissue,
people
more
talk
cells.
about specular microscope count of 600 per
I think the more
cell.
important, as Jeevan very nicely said, is let's look at the vision of the patient. I had, believe it or not, a VVIP patient just recently. She was 6'6" and about 78 plus, and she was advised triple. And I told her, why you go for it? Actually, I didn't even advise the cataract because she was 6'9", 6'6". So I think I would
think,
stick to what Jeevan said.